To quickly understand the murmurs, we need to understand the pressure gradients in the chambers of the heart. So, to start with the aortic valvular diseases, we need to look at the pressures of the left ventricle and the aorta. In aortic stenosis, the major problem is that the blood cannot go from the left ventricle into the aorta, so there is going to be left ventricular overload, right? Now, during systole, this ventricle therefore there's going to be a lot of turbulent flow, and therefore we are going to get a mid-systolic ejection murmur in aortic stenosis over here. Along with that, because the ventricle eventually becomes non-compliant, there is an S4 that may be heard. Most importantly, paradoxical splitting of the S2 heart sound may be seen. So at this note, let us understand all different kinds of splits. Normally, during inspiration, because there is a decrease in the intrathoracic pressure and increase in the venous return, there is increased right ventricular filling and increased right ventricular ejection time. Therefore, this causes delayed closure of the pulmonic valve as compared to the aortic valve. So P2 closes much later than A2. There's also another reason, but it's unimportant. Normally, let us also remember that even in the alphabet, P is followed by A, right? So that is normal. So A2 closes before P2, and this is exaggerated during inspiration. This is normal splitting of S2. Wide splitting will obviously occur when P2 is further delayed, and this will occur in conditions of delayed right ventricular emptying like pulmonary stenosis and right bundle branch block. A fixed splitting is going to be seen when there is equalization of pressure on both the sides, on the left and the right side. Therefore, there is not going to be any delay in the closure of the pulmonic valve, and this is usually seen in atrial septal defect where there is a left to right shunt. So, if there is obviously left pressures are always higher than the right pressures, right? And when there is an atrial septal defect, there's going to be equalization of pressures. In paradoxical splitting, what happens, and this is what we were discussing in aortic stenosis, there is going to be a delay in the closure of the aortic valve, which is on the left side, okay, as compared to the pulmonic valve. So now here P2 becomes earlier than A2, which is the opposite of normal, and therefore it's called paradoxical splitting of S2. So to summarize, we're going to have an ejection mid-systolic murmur along with paradoxical splitting, and the Gallagherdian effect is that the murmur radiates, usually the high-pitched part of the murmur radiates to the apex of the heart. This is the murmur of aortic stenosis. Now compare this with aortic regurgitation. The entire game is about diastole. So although the same systolic murmur is going to be heard in AR as well, because there is the same left ventricle is still overloaded with volume. However, the main game occurs here during diastole. What normally occurs is aortic pressure is around 80, whereas left ventricle is only 10. But the aortic valve normally is closed, therefore there is no backflow of blood, and only the left ventricle is receiving blood from the left atrium. In regurgitation, obviously, this valve is lost. So there's going to be a backflow of blood resulting in a lot of volume overload. If we see the gradient in the diastole between the aorta and the left ventricle, this gradient is what causes a backflow of blood and most of the signs and symptoms in aortic regurgitation. Now, as diastole progresses, the gradient will reduce, and therefore the murmur that we hear is going to be a decrescendo diastolic murmur. So to repeat, in aortic regurgitation, we are going to find an ejection systolic murmur with, more importantly, a decrescendo early diastolic murmur. Again, when the murmur radiates to the apex of the heart, it's called Austin Flint in AR, and Cole-Cecil murmur is the one that radiates to the axilla. There are also a lot of different signs in aortic regurgitation, and everything has to do with volume overload. So you have the water hammer pulse, the lighthouse sign, which is to do with the forehead. Landolfi's sign is the alternating constriction and dilatation of the pupil. Becker's sign is the retinal artery pulsations. Rosenbach is on the liver. Gerhard's is on the spleen. Traub's sign as the pistol shot sound over the femoral arteries. Hill's sign is the SBP of lower limb being more than 20 than the upper limb, and Muller's sign is the systolic pulsations of the uvula. I think they ask this sometimes. To understand the mitral valvular disorders, we need to compare the pressures between the left atrium and the left ventricle. So again, in mitral stenosis, it's very easy. Blood cannot go from the left atrium to the left ventricle because the mitral valve is stenosed. Therefore, left atrial pressure will increase. And obviously, this is going to be more pronounced in diastole when the left atrium contracts and wants to. There's going to be more turbulence of blood during diastole in the left atrium. In mitral regurgitation, on the other hand, it's very easy that the mitral valve basically is not able to close entirely during systole. So left ventricle is going to continuously, along with the aorta during systole, if this gets confusing, left ventricle, left atrium, along with the aorta during systole, blood is also going to go into the left atrium because of mitral regurgitation. So now quickly seeing, in mitral stenosis, there is going to be, like we discussed, a mid-diastolic murmur with a pre-systolic accentuation and pre-systolic accentuation is basically like the last resort of the atria trying to contract and push blood into the ventricles. So mid-diastolic murmur along with a pre-systolic accentuation, and in mitral regurgitation there's going to be a pan-systolic murmur because blood is going to go from the left ventricle into the left atrium along with the aorta during systole. So to summarize quickly, basically, aortic murmurs, we have aortic stenosis where there's going to be systolic ejection click with paradoxical splitting of S2. Aortic regurgitation, which will have systolic ejection click along with a diastolic decrescendo murmur. Mitral stenosis will have an opening snap with a mid-diastolic and pre-systolic accentuation, and mitral regurgitation will be a pan-systolic with S3, which is suggestive of volume over.